From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
All right. Well, good afternoon for those of you on the East Coast, and good morning to all the other time zones. My name is Laura Evans, and I will be your host for this episode, number 246 of the Crisis Jam. And today we'll have a fireside chat with Dr. Deborah Haskins, moderated by Dr. John Draper, on trauma-informed insights into gambling addiction. But before we hop into our featured presentation or our lead story, I'm going to turn it over to David Covington for 2025 Wrapped.
Thank you so much, Laura. If you've been on Spotify, you're a music listener, you've seen your top artist, top genre, how many minutes this year. You may have even seen your musical age. Spotify says that my playlist suggests I'm in my 40s. Yeah, that's not the case. So we're going to do Crisis Jams Wrapped for 2025. Let's do this. Our first ever. It's a little surreal to say it out loud because it's just been a little over 5 years ago that Dr. Richard McKenna and a handful of us were coming together. And with 988's launch and crisis services expanding, we're now seeing a movement that is literally in the thousands. But it's not about the numbers. It's about the people. It's about the impact. And this year you showed up and that mattered. So let's think of some questions that we want to answer in our Wrapped, similar to that Spotify recap. Which episode topped your list? You probably have a favorite. How many minutes did the learning community spend watching? And we kept track. And new concept for you. What jammer badges did you earn this year? We'll see those here. We started in January with a presentation on the 2%, those involved in law enforcement and 988 and that topic. We'll end the year in Fort Worth with a visit to JPS's psychiatric emergency room. But along the way, it was 45 Wednesdays at 12 noon Eastern time. One continuous community from episodes 203 to 247. We missed just 4 weeks along the way with all the transitions. We showcased innovations in 15 states this year. And for the first time, we went out. We went to Salt Lake City to see the Huntsman Mental Health Institute's new crisis care center. We went to Columbus, Ohio to see the Adam H. Franklin County Crisis Care Center. And again, we'll be going to Texas. We had 3 presentations from programs in California, but we featured 15 states overall as we showcased what can be done as we're working to provide better crisis care. So how many of you actually showed up? You were in a Zoom meeting like this one. You were live on the YouTube live stream. Thank you for those of you who joined that this year for the first time. We made that new option available. If you looked at everyone who showed up, it was about 12,000 total. Now, that 12,000 is duplicated. So some of you were here all 45 times and others came 2 or 3 times, or today might be your first Crisis Jam. But live in the moment and together. Or it wasn't live. You missed the Crisis Jam and you came onto our YouTube channel at 5 Lanes, 1 Road to Recovery. The engagement didn't stop. We've got all the episodes going back to almost the beginning of the Crisis Jam. And there were nearly 90,000 views this year of those. If you add up the time, it's 6,400 hours of connecting. If just one person sat down to watch that much YouTube, it would take 9 months of nonstop watching. So we were thrilled to make engagement not only live, but later on YouTube. The way we did this is with the hosts and voices that carried the jam. And thanks so much, Megan, Laura, Dr. Sims, Brian, Dr. Chuck, John Draper, and others who hosted or moderated a debate or helped us carry this year. Megan jumped to the front of hosting the most times. If you include moderated debates in there, Laura edged her out. But even then, those of us who host, we're simply the equivalent of flight attendants that hand out drinks during the jam. The people who fly the plane, Karen Jones, Kristen Ellis, and their team, operating behind the scenes and supporting everything we're doing.
The time has come for this.
So Cookie Monster brings us to the over-under, and today in our special Wrapped 2025 version, we've got Miriam Delphin Rittman and Susan Lang. Welcome. Thank you both so much for being here. Miriam, we've got a long way to go, but we've come a long way since you kicked us off when 9 at 8 went live in July of 2022.
Yeah, I mean, so exciting. Such important work has happened. So we're just thrilled that this community has been such an important part of that work.
And Susan, you've jumped in, are becoming a regular with workforce updates. Susan, Miriam, the room where it happens, big conversations, fast trivia, breaking news, and moments that only happen live. How many unique voices stepped up to the Crisis Jam mic in 2025? That's the unduplicated total of people who gave featured presentations, participated in debates, gave news updates, SAMHSA and NASBIT updates, and all the other segments we have. If you add them up, we had 45 episodes. How many unique people were on the program? I don't know. Miriam, you want to give a number and Susan say over, under, or the other way around?
Go ahead.
Yeah, so Susan, what do you think? Shall I just pop out a number? Let's say 200.
200 is a great guess. Susan, over or under? And let's see our audience as well. 45 episodes, we would have had to have, goodness, 200 would be a lot of unique speakers every week. What do you think, Susan?
I'm gonna go under because I think, 2 or 3 people a week would be under the 200. So I'm gonna go under.
Yeah, under is the way I would guess too. Here's the challenge. When the cookie gets cut so dang close. The actual answer, Miriam, this is everyone. Miriam, you'll see your name. You've been in the trivia hot seat for one thing today, right there in the 5th column over, right under. And I see you up in the upper right there. But if you add all those together, it is almost exactly 200. So hard to cut when they just get the cookie just right. Susan, great job. I would have guessed under as well. Let's keep going. We're going to come back to the two of you for another question here in a moment. A nod to John Draper with his catchphrase for the Crisis Jam when he hosts. Our jam came in every flavor this year. For the first time, you didn't just see featured presentations in 15-minute blocks, but fireside chats like we have today with Dr. Haskins. We had more debates in 2025 than we had done in the history of the Crisis Jam with 5. We did 4 days in the life where mobile crisis staff, people who supervise facilities, people who work in follow-up, and people who work in call, text, chat hubs were here. And 2 amazing special events, including our Battle of the Bills. 5 formats, 1 community. Now, actually, Megan and Laura were not on the program the most this year. Someone was on more than them. This person was in the trivia hot seat. They did a featured presentation. They were in a round table a couple of times. So who was our most frequent guest? I don't think it takes a long-term crisis jammer to know that that was King Richard. 13 appearances by Dr. McKeon this year. And Richard, if you're on, I hope we've righted the wrong of the universe when I had that LA Dodgers picture of you. Richard, does this even? Are we square now? Richard's on mute. And Richard's still on mute. Richard's on mute because he's on his phone. Richard, we have just today, actually yesterday, we were working with Miriam. We have disabled the second security step that's just too much, so that hopefully, Richard, next week you can be on your regular computer on the jam. We think we fixed it.
Oh, well, that's great. I'm now unmuted, and thank you, David. We are now square. Thank you for substituting the Yankees for the Dodgers. That does my heart good.
You got it. Now, why do we do this, Jam? The crisis movement really is about a host of things. Just one metric: 18 to 20 million people come to hospital EDs every year. They did that in 2025. And they do that not because they need medical care. Most don't. Most need to be seen. And this is the 24/7 capability that's available. Our system just hasn't been built for that. But this movement is no longer just theoretical. It's showing up in communities since that first Go Live event back 3 years ago, 3.5 now. We're starting to see movement. One of the indicators this year that was the most encouraging to me, showing that progress, is Ted Letterman and the National Research Institute showing over 1 million mobile crisis responses in 2024. As we see this capability coming, this is what the beginning looks like. So our trivia question for the day: what was the episode of the year? What moved you most in 2025? Is 988 a tax or a lifeline? The debate with Tom Betlock and Hannah Wesolowski about how to fund Show Up for Youth with Sophie Shev and Michelle Zabel. Big Feelings in Real Life, the episode with Dr. Chuck Browning and the Grafton leadership, or the Live from Salt Lake. Let's put the poll up and see. Susan, do you have a favorite episode that impacted you the most from the year?
I would choose B. I also come from doing many, many years of direct service with youth and young adults. So that one in particular spoke to me.
And Miriam, what about you? Miriam?
Yeah, okay, I was on mute there. Yeah, I was going to select that one as well because I know Sophie and she is just such a change maker and just doing such important work in this policy space and so really showing up with great energy and ideas. So I think that one as well.
And we're seeing answers across the board. In addition to our the most common appearances with Dr. Richard McKeon, we had an architect of the movement who really amplified and brought the wind into the sails of this work, and that's Dr. Brian Hepburn with NASBID. Every state at the table, leadership that changed what was possible. Thank you so much, Dr. Hepburn, for your support in this key transition year and building this movement from the get-go. Now, our concept of badges, you'll probably see these in the real world soon, but founding jammer, Miriam is one of our founding jammers. If you've been in a trivia hot seat, you've been a featured speaker, you've participated in a debate, you bring the experience supervising, managing, funding, or working in a crisis service directly. You're a regular who's here week in and week out, or you've participated in one of our international forums. We'll have our next one next July with NASBID. So Spotify wrapped style. Now, we haven't automated this yet, but we have created, Richard, here's yours, the badges. Now, Richard has all the badges except he has not yet been in a Crisis Jam debate. So Richard has one badge left that he needs since joining in 2020. If you'd like your own virtual set, thanks for Laura Evans for thinking of this idea. If you'd like a similar wallpaper, let us know which badges are yours and when you started in the jam, and we'll send that to you. So thank you all so much for showing up. It makes a difference, and we look forward to working together again in 2026 as this learning community carries this journey forward. Laura, thanks so much.
All right. Well, thank you, David, with that great wrapped. Let's now get into our lead story. All right. And so for this fireside chat, I am pleased to introduce Dr. John Draper, who is the president of Research, Government Solutions, and Development for BHL. Dr. Draper.
Always great to see you and great to be here with you all. Dr. Deborah Haskins is a seasoned scholar, practitioner, retired director of counseling programs, and an associate professor in counseling at Trinity, Washington, D.C. And she's also a lecturer at Johns Hopkins. Deborah specializes in mental health services specifically for culturally diverse communities and has over 30 years developing her expertise in disordered and problem gambling prevention. That also includes problem gambling treatment and community wellness. So welcome, Dr. Haskins, to the Crisis Chat.
Thank you.
I know you call yourself Debbie. Do you
Thank
mind if I do the same?
Yeah, that's fine. Yeah, it's great to be here. I love this. I love this.
Welcome.
I love what you all are doing.
I do too. And
Yeah,
I'll tell you what I also love is sports. I'm a big sports fan, and I can't watch
same
sports
here.
without seeing advertisements in stadiums and during televised games for FanDuel and
Hmm.
DraftKings, similar apps. So with the rapid expansion of sports betting, online gambling, mobile apps, and so on, what are we seeing in the way of increased gambling related problems and what people are most affected by them?
Yeah, yeah. Gambling has been going on for a long time. I mean, that's the reality. It's a form of entertainment. People have been gambling in their communities, unregulated and regulated. And with the uh, creation or expansion of online gambling and sports betting, what it has done, it has increased the accessibility because now you can just um, do it on your
Hmm.
device.
Yep.
You can use your laptop, top. You can use whatever device you have access to 24/7. And that includes people gambling at work. And
Yeah.
so, we know that it has increased the opportunity and the participation rates. And our gambler helpline, crisis helplines, we're getting more calls. And the high risk profile we have the most is the 18 to 34-year-old European visible white male, as well as men of color. But we also see people, from every um, type of background. We see young people. First of all, young people enjoy sports. Young people are very technology literate, and they are not afraid of technology. And so when we opened up sports betting and online gambling, we also know that opened up for a lot of our youth. And that's a big concern that we have because, of course, the brain is not fully developed until age 24. And so you have youth who are engaging in risky behaviors before they really, have good judgment making skills.
Yeah, and being so interested in and now engaged with finances and financial problems at such a young
Hmm.
age really digs a deep
Absolutely.
hole. You've noted in the past that about, I mean, less than 5% of individuals with gambling disorder actually seek treatment. So Debbie, from your
Yeah.
experience, what are the top three things that, stand in the way, obstacles that are act as barriers for people getting treatment? And what do you think we could do about that? Is there something in particular, one thing you'd focus on to help us
Okay,
get
sure.
here?
Sure. So I would say three top areas that we could focus on what I see. Number one, people don't see gambling as a problem. So we have to deal with the language of what we describe. Because if we call it problem gambling, which is really the language that we use, problem gambling, a lot of people see it as entertainment, but they also see it as the solution
Yeah.
to real problems that they have. And so we see a lot of people who are struggling to live. We have people who don't have access to, equitable access. We have people who are in rural settings, for example, who don't have transportation that's done well, where they can get access to the better paying jobs. We have people in even some of the suburban parts of where we are, people around the globe who are really struggling. And so for them, they see it as a solution to real problems that they're struggling with. So that's number one. We've got to look at the language because when we describe it as problem gambling too, if a person is thinking this is a solution to something that's going to help me solve a real problem, they're not seeing it as a problem in gambling. They're seeing it as a problem with finances. They see it as a problem with their, job not paying a livable wage. For example, I think a
What's the
second
problem with
barrier.
your landlord who won't accept the fact that they can't pay their rent? Just wait till the next time I win.
Absolutely, absolutely. And I think a second issue that we see is the fact that we have a lot of people don't have access to treatment. Treatment is not necessarily, particularly gambling treatment. First of all, you don't have every practitioner or more practitioners who are trained in gambling addiction. And so that's why we want people to integrate it into their behavioral health services, integrated into just short screens. But basically what I'm saying here is that, if people don't have access to treatment. So for example, I remember one state where I asked the question, well, do you have addiction treatment in the areas of your town or city where people are struggling with material poverty? And they said, no. I wanted to scream, because how then is someone supposed to get access, particularly if you have people who are already living on the margins and they don't have transportation, particularly when their car has been repossessed, or they don't even have money to get to treatment that's on the other side of town, or maybe they don't even have a device that they can do telehealth. The third issue that I would say is that we also have to recognize that people are doing, this is what I usually say, people are doing group therapy in their own communities. And what do I mean by that? I mean that when people look at their struggle, they're typically going to use the resources that are more native to them, the resources that are more familiar to them. When we look at cultural communities, many cultural communities do not trust Western healthcare because they have experienced harm in those healthcare systems. They have experienced structural experience or systemic issues around race, ethnicity, class, etc. And so I say that to say that what I would like to see more is I want to see more practitioners and preventionists actually at the grassroots level in the community. If we get in the community, let me give you a quick example. Last Saturday, I did a grief and loss workshop at a church. We had had snow the night before, so I didn't know who was going to actually show up. This was at a Black church. There were 50 people there. That's an example of people are doing group therapy in their own communities. Those are 50 people that got information where I talked about how people self-medicate when they're struggling with holiday grief, as well as other grief and loss or traumatic experiences, And so I think those are three areas that we want to open up, because the reality is that 1 to 5% that we use, we really don't know what the real percentage is. Why? Because usually the research is based on clinical treatment seeking. So the question is, what are we doing for the other 97%?
Right.
Or
That's
98%?
really important points that they need to get out into the community. It sounds like it's part of this is both prevention, but also just being able to have people become more aware of the problem. And then if we can
Absolutely.
get them in care, if we can't
Mhm.
prevent it, then we can do something about it. But this notion, like I read a statistic recently that 1 in 5 people struggling with gambling addiction are going to attempt suicide. That's the highest rate of any addiction
Yes.
or substance use disorder. So
Yes.
when we can get them into treatment, or if we're
Yeah.
treating co-occurring disorders, as you know, just kind of integrate it into our regular care, and then they bring up or screen for problem
Yeah.
gambling. What
Hmm.
what should the clinician do in treating them that's similar to or different than perhaps treating substance use disorder?
Sure. Sure. Well, one, we do have to assess and screen almost in every session, because the trauma of gambling harm is real and is painful. You've lost your job, you've lost your money, you don't have um, money to purchase food. One of the persons that I was supporting, he only ate cereal because that's all he could afford. And so people get to a point where they say it's better for me or my family not to be here. So I think that behavioral health providers, as well as practitioners, medical professionals, what we can do is incorporate those short screens in in our typical intake. So we can ask direct questions and indirect. So if you ask a person, have you gambled in the last 6 months or the last 12 months? A lot of people aren't going to respond to those like medicalized or psychological questions. But if you ask them indirectly, what do you do for fun?
Right.
How do you spend your free time? Then you're more likely to get more information where you can then have other conversations. So one of the areas that clinicians are not familiar with because we have not been trained in this is to how do you talk to people about their money? How do you really focus on, because it's not about the money when there's been always about the money. And so don't want to suggest that it's all about the money, but the reality is money is one of the symptoms that get people caught up. But also when people have their first win, and then now the brain is sending a message to the amygdala to say, I feel good, that's exciting, let me do that again. I want to have more of that. So we want to give clinicians more information and more education about gambling addiction so that they can share the information. They can start increasing the emotional awareness around their staff members as well as their consumers. But we also have to train them how to have conversations about the money, because you're usually not asking people, well, how much did you spend when you gambled? How much did you lose? How far back have you been gambling? How long has this gone on? And over the course of time, how much have you spent? And then we're usually not also identifying as an intervention, moving the money out of their hands. So just like a person who is struggling with alcoholism or opiates or drug addiction, we want them to change people, places, and things, right? So the thing that's a challenge is money, because you need money to survive in most societies. I'll say in the United States, you need to have money, right? And so how do we help the person when their drug of choice, if you will, involves money or material resources that keeps them in action? So, for example, our young people are going to use whatever they get access to. It could be their clothing, their sneakers. They may actually, in their terms, borrow a parent's credit card. So I would say those are some recommendations, but also we also know that cognitive behavioral therapy is the best model of choice to provide some change. But we also know motivational interviewing, just as we use with other addictions. Some of the same models that we use are similar here, but the difference is we're going to be needing to be very specific about the gambling, because it's not the same as an opiate addiction or the same as alcoholism.
Right. That you mentioned the community approaches are so important because it sounds like a lot of this is about awareness. It's about language. It's about who the messenger is. And it
Yeah.
sounds like you were noting, a lot of faith-based approaches. Obviously, we see that in 12-step programs. It's huge. And so it does sound like that's a natural place to get out the message and have conversations, not just telling
Yes.
people you've got a problem, get into to therapy. But in general, it sounds like we need a public health approach in general,
Absolutely. Yes.
especially when you've got FanDuel and
Yes.
DraftKings out there. So can you give us a sense of what kind of public health messaging, like we've had it with quitting smoking and drunk driving, what kind of public messaging do you think we should be implementing to reduce problem gambling?
Good question, and it's very important. A public health approach, a comprehensive public health approach, is what is going to be the most effective. So you increase public awareness among your communities, and you talk about problem gambling or gambling addiction or gambling disorders, but in non-stigmatizing language. So what we recommend is to talk about low-risk gambling versus high-risk gambling, to talk about, how people can start to derive pleasure similar to other drugs and alcohol, etc., that now is planted in the brain, and then the brain starts to send out other messages through the other cells and the neural pathways in our bodies, et cetera, et cetera. So public awareness has to be a big part of that approach. The second thing is to make treatment available by qualified practitioners who have gotten training about gambling addiction, problem gambling, and we actually do have a certification program that's available through the National Council of Problem Gambling. You can get information there, or you can go to the International Gambling and Gaming Certification Board. So we want practitioners to really understand what is different, what is similar with other drugs of choice and alcohol, for example, and other process addictions. And then the other component that's very important in this comprehensive public health approach is to incorporate people with lived experiences. We know that for a lot of people, who they're going to listen to with more credibility is not to me or to a Dr. Draper or a Dr. Haskins or a social worker or psychologist. This is someone who is more clinically and medically trained, but they're going to talk to someone who gets their story, someone who has been in the trenches, who has breathing gambling addiction trauma, the trauma that affects them. And for many people, they've come into this experience because they had unhealed traumas. And so when they talk to people with lived experiences who get their experience, then that's also helpful. And they can access people through Gamblers Anonymous, Smart Recovery. We have other available resources that you're going to hear on this episode, such as Evive. But we have many resources that can help people get the access and get the help they need. And we want it to be integrated.
Yes.
So integrate the family, because the family is the client. The family is the client, because when you focus on healing one person at a time, then the family is healed.
It is a problem that affects everyone who loves and cares about the person, like many addictions. And we see the black curtain that has been drawn in front of us. Laura, it looks like that's it for our fireside chat with Dr. Haskins, but perhaps there's a roundtable ahead of us.
Oh,
Thank you.
There is, John. Thank you so much, Dr. Draper and Dr. Haskins. We are going to bring our roundtable together because I think there's going to be a lot of thoughts, comments, feedback, questions. I see them in the chat already. Make sure that you put your thoughts in there. But first, I'm going to ask Dr. Rochelle Head Dunham to share her thoughts and comments on that fireside chat.
So thank you, Laura, and absolutely thank you so much for this conversation, which is extremely important in the context of 988 and crisis work, since this particular group of people experience more crisis than I think we are keenly aware of. I also want to thank Dr. Haskins, who I tremendously admire and has had the opportunity to work very closely with her with the work she's doing at our district, training our professionals to do the integrated work and to do the certification, because we don't have enough people who understand gambling, and we have too many people who come in contact with gamblers unknown to them. And so making sure that the people who are on the front lines of care understand it. And then this whole public health approach, I absolutely endorse that. Additionally, I tremendously am thankful for Dr. Haskins collaborating and bringing to our agency Sam DeMello, who you'll hear from, who is the developer of the Evive app. That app really is a game changer, and the approach that is being taken is to roll that out as a statewide effort in Louisiana, using our agency as an incubator that works very closely with his company to develop aspects of it, including how to integrate it into the treatment setting by clinical professionals. And so my advice to those of you who are on this call is that you get with Sam, you get with Dr. Haskins, you work out these trainings that they've done. If you want feedback from Metropolitan in terms of how we're doing this, we are available to you. But that app is something that I advise all states to look into, advancing in the care of those who are suffering from compulsive gambling disorder. Our efforts are centered around the younger population, 18 to 35-year-olds, schools, colleges, military, church-based individuals, because the problems start early. And if they live to be 50, 60, it's a blessing. But in order to help them get there, it's really important that we all wrap our arms around this problem.
Thank you, Dr. Rochelle. And that's just stunning right there, right? If they make it to 50, 60, that is very powerful reminder of how impactful this addiction may be. So that's a great segue. I'm going to bring in Sam D'Amelio for your comments, thoughts, and feedback.
Yeah, thank you so much. This is my first Crisis Jam, and this is incredible. It will definitely not be my last. This is great. So Dr. Deborah Haskins is someone I admire a ton. She is the chair of our clinical advisory board here at eVive. Um, I have spent my career in the technology industry, and personally, I'm about 6 years into recovery from my own gambling addiction. And that was the biggest secret in my life forever, basically. I have a very common story in the United States. I started gambling when I was 12, playing poker when, the poker boom happened. My parents were very supportive. They loved that I was in the basement, maybe losing 10 or 20 bucks, but I wasn't running around town drinking and doing drugs. They saw this as a great thing. From the jump, I had problems controlling my time and energy and money that went into gambling, but I had no concept of what gambling addiction was. I did not know that was something you could be addicted to. And then when I turned 23 after college, I got introduced to online gambling and sports betting. And I went from a $5 bet on my local Golden State Warriors in a bar with my friends to a $200 bet on Ugandan women's volleyball online on an app at 2 in the morning in probably 60 days. And I spent the next decade of my career working 80 or 90 hours a week at these big tech companies in these big jobs and lighting all of my money on fire and becoming more isolated and ashamed. And eventually, when I was 30, I tried to get help. And unfortunately, I went to someone who had no experience helping people with a gambling addiction, and it did not resonate with me. And I went to Gamblers Anonymous, which I think is a great organization. But from my personal experience, I was the youngest person in the room by 30 years. I was talking about gambling on an app on my phone, and these guys were talking about, the horse track in 1978. And it left me feeling really isolated and ashamed and like I was somehow the black sheep in all of this, that the system was not designed to help people like me. And I continued with that thinking for another 5 or 6 years, and my life fell apart, and I got to the point of suicide. And very luckily, I got engaged, and my fiance gave me an intervention and basically said, hey, I don't know what is happening with you, but you need to tell me or we're not going to get married. And she helped me get into recovery by really breaking that isolation and kind of opening up my support system. And as I started to look at the challenges around problem gambling, which I think, Dr. Haskins really eloquently articulated, I said, man, so much of this could be solved with technology. Gambling companies are using technology, like every other tech company, to make their products accessible and personalized and engaging. And on the support side, our main entry point into the system is a 1-800 number. And it is typically marketed as, are you a degenerate who has lost everything? Call this guidance counselor. And then we sit around and we say, man, that's really strange. We don't see 20-year-old men coming into treatment. Of course we don't, right? We are not meeting them where they are. So I set out with the help of Dr. Haskins and kind of clinicians like her to build a digital mobile application that supports anybody at any stage of their relationship with gambling. Treatment and recovery support is incredibly important, but as Dr. Haskins mentioned, only about 3% of people that experience problem gambling ever reach out and seek support. So in addition to that, we also offer a harm reduction model and a prevention model. And this really, capitalizes on the sober curious movement of I don't see myself as a quote unquote problem gambler or an addict, but I don't like the way that gambling is showing up in my life, and I want to do something about it. And so by being able to access this mobile application without having to talk to somebody at first, it gets more people engaged in the system. And then instead of sending them a 100-page PDF with all of these resources when they are in crisis and they can't make sense of it, we use technology to really match them with really resonant resources. Somebody might be a better candidate for counseling or peer support or a faith-based organization versus a more scientific, methodology of addressing their challenges. And so what we find with Evive is it's really an amplification of the entire system. The product itself delivers things like behavioral tracking and journaling and comprehensive education and tools like guided meditations and urge surfing exercises that they can access 24 hours a day, just like they would access gambling. But when we work with a state like Louisiana and all of the wonderful people on Dr. Dunham's team at MHSD, we actually digitize all of the existing support within a state. So Evive becomes a modern version of the helpline. And someone could come in there and find, hey, here is a certified counselor in my own community. Here are people in my own community that are, sharing my struggle that I can talk to. And I think to Dr. Haskins' point, when you're struggling with gambling, you feel very different. You feel it's very Jekyll and Hyde, right? The rational side of my brain knows that this is ruining my life, but I can't seem to stop. And so I think connecting them with this community-based approach of other people that are there to support them that have walked through the fire, we find very impactful. When we look at our data, it takes about 10 days or so of people engaging with the application and the education before they eventually reach out for support. And we can actually track all of these people by zip code and demographics, and we can start to see, the population of 45-year-old African American women that are primarily gambling on slots in a brick and mortar casino need these resources, and the 20-year-old college-aged kid who is primarily gambling online with cryptocurrency needs these kinds of resources. And it really enables us to empower our state partners to show up for their communities and their constituents in a real way. So we have
Sam,
about
I want
10.
to,
Oh, sorry. Yeah.
yeah, I just want to start by saying thank you for sharing your story. Thank you for still being here, and thank you for being on the jam. There are a lot of comments here in the chat. If you, Dr. Rochelle, Dr. Haskins, want to reach out, I think there's some questions on how to spot this if your friends or family. Would love for you to keep that going because this is so fascinating. And really illustrating, right? If people start at 12 and then aren't getting help until their 20s and 30s, that's a long time in this addiction. So just appreciate you sharing your story. And thank you to all of our roundtable and Dr. Haskins. Now I'm going to turn it to Bethany Myers, who's going to give us a SAMHSA update.
Hello, good afternoon or good morning, everybody. So just some brief updates we have from SAMHSA. We held a webinar yesterday. Last week, it was mentioned on the Crisis Jam. It was a state peer-to-peer webinar about children, youth, and family crisis stabilization services. And we had the fantastic states of Colorado, Connecticut, and Idaho presenting. And we had 158 participants in the webinar with us. So the peer-to-peers are absolutely wonderful. They do eventually get put up on our website. The next round, or next webinar of this series. Hopefully will be in February is when we're aiming, but stay tuned. The 988 office also has a webinar coming up in the very beginning of January about partnering with emergency and first responders and dispatching call centers. And I have a link to the information for this webinar. So I will put it in the chat right now so everyone can get to it. And that link is also super important because if they have some other webinars that come up with their training and technical assistance partnership, like that's where it will be. So keep an eye on that link for some future stuff. Just to update and to touch base on, so you know that we didn't lose track of it, is that SAMHSA, we are still working on updating the crisis national guidelines and the definitions, and we are still continuing to work on the mobile crisis teams guidelines. So, you know, we're still working on them. We're still chugging along on them, just so you know that we haven't forgotten. But that's the biggest updates I have from SAMHSA. So thank you guys so much for having me, and I hope you all have a wonderful day.
Thank you so much, Bethany. Make sure we all bookmark that link in the chat. So now I'm going to turn it over to Dr. Jessica Pollard for an update from NASHBID.
Thanks, Laura, and hi, Crisis Jammers. I am going to just give you a couple of quick updates. I love that there was so much discussion of technology and supporting people with different challenges more effectively, because that's a piece of what I'll talk about, but I'll admit that it's mostly a teaser for what I want to talk about in more depth in an upcoming Crisis Jam, which is the Digital Mental Health International Congress that I was fortunate enough to participate in a few weeks ago in Toronto. And that was attended by at least, the last count I saw was 44 countries, representatives of 44 countries across all 7 continents. And maybe you think I'm saying that in error, but no, there was a group participating from one of the Antarctica stations. So we truly had all 7 continents. And that took place in Toronto. It started out with a UNICEF expert advisory group on implementing digital mental health solutions for children, adolescents, and youth. Another pre-conference meeting was a think tank on from fragmentation to connected care. And then a 2-day conference. And I want to come back on an upcoming Crisis Jam to share more of the key takeaways learned from that conference. But today I'm just going to spend a few minutes encouraging you to participate in a crisis survey. It should be a national survey, or is a national survey, of mobile crisis programs funded by the Pew Charitable Trust. That opened on December 1st and will close on January 31st. That is led by the New York State Psychiatric Institute of Columbia University and some former Crisis Jam presenters and research collaborators of mine, Drs. Leah Pope and Michael Compton, and Dr. Amy Watson, along with Dr. Matthew Goldman and Preston Looper. The intent there is to include behavioral health provider mobile crisis programs, mobile response and stabilization services, law enforcement-based co-responder programs, and alternative or community responder programs. So all of those, I'm going to put a link in the chat to the survey and encourage you to participate, not just because there is a chance to win a gift card and a raffle, but because we fully expect that our colleagues conducting that survey will come back to us in a future Crisis Jam to present the findings. So really important insights that we would expect to come out of that survey around how are teams structured, what training do they receive, how are they financed. So please do participate so we can get a look at the national landscape. And I will put that link in the chat as I mentioned. And thanks for letting me share that. Back to you, Laura.
Thank you, Dr. Pollard. That is a lot of stuff going on. So make sure you guys also bookmark that link once it's dropped in the chat. And it sounds like, you know, jammers today have an opportunity to win multiple times. One, for participating today in the chat, you'll get a chance to win that coupon code for the Crisis Jam store. And again, through your survey, Dr. Pollard, or maybe not your survey, but once you share the link. So it pays to be on the jam. All right. Well, now I'm going to turn it over to Samira Schreiber and Daniel Heron. Samira is from NAMI and Daniel is from Vibrant. I'll turn it over to both of you.
Great. Thanks, Laura, and good to see everyone. We have just a couple of state legislative updates to share. I'm going to start in Wisconsin. Last month, Wisconsin enacted a new law which grants liability protections for 911 PSAPs, those public safety answering points, and 911 call centers when they're transferring calls to 988. This is something that we've been seeing in a lot of states so far. Wisconsin's joining Nebraska, North Dakota, and Washington that have also adopted these similar laws that provide good faith liability protection for that transfer of call between 911 and 988. And that liability protection is sort of a sticking point that we're seeing in a lot of states, and just with some concerns around what happens if something happens during that call or if the call is dropped. It works on some of the 988 911 interoperability issues. I think that's all I have in Wisconsin. I will turn it over to Samira, but before I do that, I just want to mention that we are warming up for the 2026 legislative session, and we're expecting to have a lot of updates coming in the new year. So go ahead, Samira.
Great. Thanks, Daniel. I just have two updates. New Jersey has a 988 fee bill. It's S4502, and it passed its first committee. This would establish 40 cents and would bring in about 60 million annually. And then DC also has a 988 fee bill that's pending. It's B260462, which is a 76-cent fee. And has had its first hearing today. I haven't had a chance to fully watch it yet, but I heard that it had a lot of good support testimonies. So those are all the updates I have. Thank you.
Well, thank you both so much. We appreciate all the tracking that you do for those policy initiatives. So before we move over to our headline and encore thanks, I'm actually going to I'm going to do a host privilege and bring Sam D'Amelio back if you are still here. Because I had a particular question and I would love to get your perspective on that as we think about young people getting involved very early. You mentioned that you got involved in gambling at 12. Can you talk a little bit more about enticing the young people? And I'm also thinking outside of the traditional gambling sites, what about those freemium games where kids are spending real money?
Yeah. So we see this all the time in our user population. I would say that there's kind of three main pathways. One is video game mechanics that mirror gambling, right? So on a lot of these large format video games, you can buy what's called a loot box, which has a, certain rarity item inside of it. And kids will pull their money, buy a loot box, and try to get something expensive that they can then resell on a secondary market. So even though they're not participating in blackjack or poker or something that we would all consider gambling, we are priming their brain and their neural pathways to engage in gambling activity. I think the other real main entry point we see to gambling at a young age is what we call casino streamers. People that are spinning slot machines or playing casino games online on platforms like Twitch, and they are streaming themselves do this live. And in most cases, they're incentivized by these gambling companies with referral codes to get younger folks to sign up for services. And they show them this very unrealistic version of gambling where they are spinning a slot machine for $1,000 a spin and they're winning $1 million live on stream and reacting to that. And it is teaching kids, like this is a way, what we would call solutions gambling, right? To what Dr. Haskins was saying. This is a way that you can empower yourself, kind of financially. So I think those are the big ones. And then obviously anyone who's watched a professional sporting event in the last 5 years, like this is all that we talk about on sports. We do not talk about player performance. We do not talk about statistics. We now talk about what is the best bet and who is most likely to hit those. So I talk to kids all the time that have been gambling for 8 to 10 years before they turn 20. And when they finally can engage in the regulated market, that they are coming in with a very high risk profile.
Wow, thanks for sharing that. That it's just stunning for me to hear about by the time they're of legal age to actually participate in the regulated market, they're already at such a high risk. There's a question in the chat, and I'll give you 30 seconds, Sam, and maybe we can
Sure.
give also 30 seconds to Dr. Haskins as well. Of how do we talk to our kids? How do we talk to our friends if we suspect problem gambling?
Yeah. So I think I always say that we will win when the sex and drugs conversation that every parent has with their kids becomes the sex and drugs and gambling conversation. I just think we need to have awareness in parents if we're going to affect youth that this is something that kids should be watching out for, especially as they transition to, college campuses and they have that level of independence in a lot of cases. I think the other thing that we can do is just try to reduce the stigma as much as possible, right? It's more appropriate to talk to somebody about their political affiliation or their sexual orientation than how much money do you have in the bank, right? It's a very taboo question. So gambling harm exists on a spectrum. Like I am a disordered gambler. I am way at the extreme of that. But you do not have to be a disordered gambler to have gambling showing up negatively in your life, right? I think the message is there are resources, there are things that you can do. Abstinence is not the only approach, it is an approach. And anything that you do to make your gambling more intentional can help relieve that harm. And, here are resources that you can access.
Thanks so much, Sam. Dr. Haskins, I know you put some information in the chat. Do you want to
Yeah,
elaborate on anything
sure.
quickly?
Yeah, sure. So mainly you want to just have simple conversations. It can be the game that's in a lot of the restaurants, where the child puts the thing in there and it has the pool thing. You get a teddy bear and then the child starts, going bonkers because they lost. So when we see our children, having a struggle with the games that they're playing, we want to just have an honest conversation with them and tell them that the game is not designed for you to be frustrated or to lose your mind or to get really upset and sad and overwhelmed. The game is for fun. And anytime we're spending too much time or too much resources, money, or you're asking your parents for more money because you want to subscribe to another one, and it's not a balance, then that's when we get in trouble. So I think the other thing is that parents and other family members should sit down with your young person and like experience the game with them. Actually say, hey, let me see what you're doing. And really get to understand the gaming because a lot of parents and family members are just glad the child's doing something that's safe. They can see them, and they
Yeah,
don't really go the extra steps. It's almost like it becomes a babysitter or a monitor for the child. And so parents don't realize that the child actually might be playing with an adult and you
right.
have no idea. And so those are just some practical steps. There's a really good book by Dr. Nancy Petrie called Pause and Reset. I'll type it into the chat. And it really
Perfect.
includes information as well as a checklist for parents who have concerns about warning signs.
All right. Well, thank you both so much for indulging me on that little extra. I'm going to turn it now
You,
for Kristen Ellis to take us home.
Thank you so much. Thanks to our headliner sponsor, AHP, and to Miriam and Susan for crushing our over-under today. Big thanks to our other opening act, BHL. And we're very excited for all of your support
to be able to keep the jam going. We do have 3 Crisis Jam gift codes that I wanted to give out today. They are going to go to Leanne Fitzpatrick, Brandy Archuleta, and Chanel Merricks. Congratulations. Please look out for an email from Marie Eddy. She will be sending you your individualized gift codes to go shop at crisisjam.shop. If you didn't win today, it's okay. We'll give away stuff in the future. And also you can join the Trivia Hot Seat if you want to get a free code, or just go to crisisjam.shop if you want to get any of your own swag. Next week, we are live and on location. I'll be there in Texas with JPS Emergency Psychiatric Center. And then the last 2 weeks of the year, we won't be here. We won't have a jam for winter break. Make sure you check out that playlist anytime you're missing us. And then in the first week of 2026, we will be kicking it off with debate number 10, featuring Jonathan Thomas and Kevin Curtis, tackling medical clearance requirements for crisis facility admissions. Thanks so much for being here. Be sure to tune in, log on, join the movement, and we will see you next week.